I'm pressing it on my end, Kemal.
Okay, we are live. Today is February 26th. We are United Medical ACO, Accountable Care Organization. Friday, our weekly events, and we have different guests for today's. 26th, we are United Medical ACO. This always happens. Okay, so I got the confirmation, so we are live. So we are going to start pretty quickly. We do have this pretty standard form for this event, for the session. So we do share the COVID updates and COVID rollout, vaccine rollout updates. So, but before I go to that, I would like to introduce our guest, and then we can start. Let me actually just click on the slide here and all right. So we have David Pence, who is one of our state representatives in House District of 18. And we have our Dr. Barnett Smith, Ronise Barnett Smith from United Medical Clinic. So I'm going to ask them to introduce themselves, and then after that, we can start the agenda items. Dr. Barnett Smith.
Good afternoon, everyone. My name is Ronise Barnett Smith. I am a family physician with United Medical Clinic in Bear, Delaware, and I'm happy to be here.
David Benz, okay, you're on mute.
Yeah, thank you. Thanks for having me. I'm David Benz. I'm a state representative for the 18th district, which is parts of Bear, Newcastle, a little bit of Newark as well. And I've been in office since 2015. Been serving as the chair of the House Health and Human Development Committee since 2017. So starting my third term as chair of that committee. So I've been closely involved with state health policy for quite some time now, and I'm looking forward to the conversation today.
Thank you. So just to kind of give the brief background on United Medical Accountable Care Organization, we have different services that we are providing, but mainly in Delaware, we are focusing on the population health management. What we would like you to remember from today is United Medical ACO represents about 116,500 Delawareans at the primary care level. We have this many unique patients in the last 12 months. And in year 2020, we completed about almost 430,000 appointments with different specialties. So this was important for us because 2020 was a unique, pretty challenging year for all of us. And for healthcare providers, it was even more. And just so that our followers would know exactly what we do and then who we represent. Now, today we are going to discuss the COVID-19 and vaccine rollout updates. And also, I included Dr. Ronise Barnett Smith. She was one of my guests early on last year, at the end of last year, I believe, or maybe the fall last year. She and I, we worked together. In fact, she's been with us, with my group for 10 years already. And she's one of those providers I respect a lot. I have a lot of respect. So I asked her if we could just, before it's too late for this month, if we can observe the Black History Month. And every time I have issues on different topics and clinical issues, I would go to her. She's my go-to person. And we also, today we have, as I mentioned, State Representative David Benz. As we are focusing on private practice advocacy, we wanted to continue our discussion. Brian Townsend, Valerie Longhurst, they were my guests before. I do I used to work with Chris Coons, John Carney in the past, and Governor Markell. I served at his transition committee in 2008 for the healthcare department. But it's been a while that we haven't talked to our state officials. And as we are the accountable care organization, and now we have the pandemic since last March 2020, we decided that it would be a great platform for us to discuss those issues with our representatives. So what I'm going to do is I always share the live data from Worldometer, so just the state level, the nationwide numbers. Right now, we are over 29 million confirmed cases with, unfortunately, more than 521,000 people lost their lives since COVID started. We still have a lot of new cases, 75,000 2 days ago, and yesterday we were at 77,000. These are big numbers, although it did decrease compared to 3-4 weeks ago. Right now, these numbers are still high, especially if you remember the beginning of the COVID-19. We weren't getting to these numbers, and we were actually afraid of these numbers, but now it became the norm, unfortunately. And then 2,500 people on each day lost their lives in the last 2 days, total of more than close to 5,000 people. So in Delaware, our focus is, this is our home state, although I was not born here. It's been since 1998. My entire US life is in this state. I employ more than 300 people and work with close to 200 providers. Delaware is our home. In fact, you don't have to be born in Delaware to be Delawarean, so which is the great part of Delaware for us. Now, the hospitalization numbers, the total current hospitalization today, we have about 164 people in the hospital COVID related. This is February 24th, that's the latest data. Usually 2 p.m. they update this. And the new admissions as of February 24th, there were 24 on that day. The day before it was 29. Percent of person testing, we are at 21.6%, while we are at 5% 7-day running average for the total test being positive. So for this part of the presentation and our discussion, I'm going to ask Tanner to give us the latest on the COVID vaccine, and then we'll start our discussion after that.
Sure. Thank you very much, Kemal. Do want to go over just some new updates that we're seeing with the rollout of our coronavirus vaccine candidates. So last week we started to share this vaccine tracker that is going to kind of keep an idea of all the different vaccines and all the different clinical trials that are going on for all of our different vaccine candidates. So we hear all the time, of course, about the Pfizer and Moderna vaccines, because those are the ones that have been approved already federally for emergency use. But we do want to kind of make everyone aware that there are plenty of other candidates out there. There are actually some others that we wanted to give updates on, especially as the Johnson & Johnson vaccine is currently under review by the FDA for emergency use and could be authorized as early as today, I believe, as the advisory board is meeting currently to discuss whether or not they're going to go forward with emergency authorization of that vaccine. So last we shared this, we do just have a couple updates. I know this might look like it's kind of the same graphic, but there are a handful of vaccines that have moved along in the process as well as entered phase 1 of their clinical trials. So it's important that we keep track of this number or as these numbers moving forward. So in terms of that Johnson & Johnson vaccine, as I mentioned, this past week, the FDA did review and confirm the safety and efficacy of the single-shot vaccine of Johnson & Johnson, especially against severe cases. So as we'll see here in a moment, when we do compare how this stacks up against the ones that are currently authorized, that it is proven to be effective against severe cases of the coronavirus, which is very promising news. So this vaccine is being again reviewed, and today we'll have an all-day meeting of the FDA advisory panel to set the stage going forward for another vaccine to enter the field as we continue to combat the coronavirus pandemic across the nation. So just kind of take a look again at our coronavirus vaccine data tracker. So how many doses are being administered across the nation, where we're at on a daily basis on how many are being administered is going to be important, as we've discussed in the efforts to reach that herd immunity moving forward into the end of this year throughout the summer. So we're looking at about, currently there are 45 million people that have received at least one dose of the vaccine here in the United States, which totals out about 66.5 million total administered vaccines, which are the ones that are actually going into the arms of people across the nation. So we did see a little bit of a dip in the daily amount that are being administered. I believe we started to talk about that this past week. So I kind of wanted to get an update on where we're heading with that. As we discussed with Dr. Hasmani, we want to see that trend upward, of course, to be able to reach herd immunity earlier. So this dip we're kind of contributing to, I know a lot of the nation had been affected by some very severe weather over the past week or so. So that could definitely be getting into some logistical issues with the rollout and the administration of vaccines in particular areas of the country. So we want to keep an eye on this, and hopefully we'll see a rebound in that here in the next week or two. So we peaked at about 1.6 million. You'll see there daily vaccines administered, trending down a little bit, but we'll definitely continue to keep an eye on this moving forward. Kemal, you might have to unmute yourself.
You know, I tell everyone the same thing, and then now I start with the same problem. So one really important kind of table for everyone, especially for public, to just see these side by side. So we put this together in terms of the Pfizer and Moderna, and now J&J, Johnson & Johnson. And this is kind of side by side comparison. The major difference between these two versus this one, this is one shot versus there are two shots. And then two shot actually did make the rollout process a lot more difficult, as we all witnessed this, not just the nationwide, but the entire world, that becomes difficult. The other thing is with the Pfizer is the storage requirements at -94 Fahrenheit. That's one of the biggest difference. And we are gonna update this as we have more updates. So now I'm gonna go ahead and start our discussions. Again, it's perhaps it's my fault that I should have covered this in the beginning of February. And you know, the thing is sometimes we don't like we are busy and we do a lot of stuff, and my team actually is doing a really good job keeping up with the current updates and maintenance items. But I think we completely forget about the Black History Month. And Wednesday night, I called Dr. Barnett-Smith, and I'm like, we need to cover this. Would you be able to join us? And because we are discussing the healthcare today, and in the beginning of our live sessions, Dr. Barnett-Smith, I think, was it in August or September I had you over?
I think it was August.
Yeah. So we were discussing that time the issues that we have with the inequity and racial disparities, and now we are seeing that on the vaccine rollout, and then having a month for Black History, it kind of makes a lot of sense for us to kind of discuss. If you can just give us a brief background why we are actually what we are celebrating, and what we can do for those who are not Black, what we can do to make this day more meaningful for everyone and for our country. So.
Okay, so I hope you can hear me. I'm on my phone and not able to access my Wi-Fi at the moment. But thank you so much for having me on, Kemal. It is important for us to celebrate Black history because it's American history. our country was founded in part on the backs of Black people of African descent that were not paid for the labor that they provided in helping to build our country. And that legacy of how we were founded has been difficult for us to overcome in many ways, but we've also come very far. But I think one of the reasons why we celebrate Black History Month is because of that disparity, because there are many contributions that people of color across the spectrum, not just people of African descent or Black people, who have contributed many great things to the country. And this is a way to highlight that, because it's not always the picture that we get to see. And it's important that we know our history so that we don't repeat it. There have been some mistakes that have been made in how we have treated one another as human beings. And it is important that we know that and we see it and not try to clean it up in order to make sure it never happens again. And celebrating Black history, including the civil rights movement and including some of the mistakes that we made, is important, because looking at what's happening with the pandemic, people being unsure about whether or not they want to get a vaccine because they don't have trust in the medical system because of things that happened in the past, like the Tuskegee experiment, like Henrietta Lacks. Those things are important because people's experiences shape not only what they see, but what they also give to the next generation. So being able to know these things so that we can help overcome them is extremely important. State Representative Bentz was on a town hall with another new state rep, Sarah McBride. And she is the first transgender politician that we've had in our state. And that's huge. Kamala Harris is the first vice president, female vice president, first woman of color vice president in our history. Representation matters. Seeing people that look like you, that share your experience, that are doing things that are powerful and that are changing the world is important. And that is why it is important that we continue to celebrate Black History Month.
No, it's extremely important also. I think what you said is really, I do want to repeat that, knowing our history, not to repeat our mistakes, right? So, unfortunately right now, outside of our country, there are different countries who are going through these issues. You guys, maybe if you are following some of the other sessions that I do, what's happening today in Tigray with Ethiopia, and still it's too late for us to be able to do anything. And we have United Nations who's supposed to be helping, but it's not just happening fast enough. And I think we are just repeating the same mistakes. But I think someone who was born in Turkey, David, you may appreciate this a little bit more from hearing this from me, like someone like me who was born in Turkey, understanding the values and why it's so important to understand what we have in this country at the level that we have is really important, because we are still one of the luckiest countries in the world as United States. And many countries are not even close to where we are. However, this doesn't mean that we have to stop where we are today. So unfortunately, with the racial injustice in terms of healthcare, we still see this as an issue. Beginning of the COVID, with the number of tests being done and with the living conditions, and now with the rollouts, it's pretty problematic from that point. And I just one of the things that I learned from Dr. Barnett-Smith is we have to be comfortable to talk about the uncomfortable. So it is not so comfortable, but then understanding it and having the conversation makes it better for all of us and make other people aware of it. But I do want to just give a couple numbers. Right now, based on the latest statistics, we have 13.4% of the population is Black in the United States. And the vaccine administration, from the vaccine admin numbers, it's 6.5% who receive the vaccines are Black. So, I do want to have a little, I'd open a little parenthesis there, because we are on the 1B and over 65, maybe this 13.4% for the entire population doesn't necessarily represent the 65 and over population. However, knowing the chronic problems, chronic illnesses, and living conditions, I would expect the number to be still closer to the population numbers. And this is true also for the Hispanic population, with 18.5%, the entire population is being Hispanic. Only 8.7% receive the vaccine for Hispanic. So that's this is kind of like validates what we have seen in the testing process. So although we didn't invite Dave for this discussion today, and I don't want to put him on the spot for this, but I think hearing it and knowing what these are from our side, from the healthcare provider side, I think it would be important for us to work on those numbers. I don't know if you would like to add anything, Dave.
Yeah, I mean, you're not saying anything we're not aware of in terms of the need to reach out to those communities and make sure that they're having access to vaccination events and that those are happening close to where those people live. We need to be better about that. It's been made clear by community groups that not enough emphasis has been put on making sure that access to this vaccine has been balanced and equitable across socioeconomic statuses. And it's something that as we continue to move through this, we need to put a higher priority on, because the way we've launched it as of now, hosting these events where we're hosting them isn't achieving that goal of equity. So we need to reevaluate the strategy and make sure that the right communities are getting engaged, knowing how to sign up, knowing where to go, knowing when to go, so that we're making sure that unfortunately those communities that were the most impacted by COVID are the rate we're going right now. They're looking like they're going to be the later ones to get the help from the vaccine, and it should be the inverse of that. So that's what we need to continue to prioritize here.
Well, thank you for that, and Dr. Barnett-Smith, thank you for your input as well. So I'm going to start our second part of our discussion. I always say this: these live sessions have become kind of like part of my therapy. So we deal with a lot of issues throughout the day, and as we were doing these, we then just realized that we actually have a lot of people we reach out to, and then we have a good way of making our points and reaching out to our people. So the primary care advocacy, private practice, rather, maybe even a better term, because in Delaware, what we have seen is with the vaccine updates, with the vaccine rollout, with the testing, unfortunately, I have seen some issues where we didn't necessarily address those problems properly, or did we utilize the primary care properly, rather. So, Dave, I know your focus is healthcare from your side. I would like to know what can be done to address some of these logistical issues with the rollout. And do you have any insight for us, like why the primary care offices are not being utilized the way that they should be? Because we are the most, perhaps we are the most equipped and experienced when it comes to vaccination, because we do that for our prevention, we do that for our pediatric population, and we are willing to do it. So it's kind of interesting in this one where we actually ask patients to go to these public places where, the day that first time DMV was doing it, the day that I was trying to change my address on my driver's license, and I find out that there was a 3-hour wait for elderlies, and then that day actually DMV was closed for those. Can this be done differently in your opinion?
So the most important thing to be able to start utilizing more partners, whether they be pharmacies and primary care physicians, which is what we want to do. You want to offer as many options as possible. And if you go into primary care and pharmacies, then you start being able to get more community level distribution as opposed to having people drive to Delaware City or something. But the biggest key to being able to do that is seeing an increase in supply of the vaccine itself. And right now that has not sped up at the rate at which we thought it would a month ago. We thought we'd be getting more now than we have been. We always knew that these first phases would have much higher demand than supply, but we did think we would see a more upward trajectory in manufacturing and delivery of doses than we have so far. So it started out with these very centralized events targeting very specific populations with the plan of enrolling provider partners and pharmacy partners. And we do have a lot of outreach from providers who want to start doing this, and some of them are doing it, but it's just so limited in what we can give, what we can provide them as a state level. To give you a little bit of insight to what sort of the chain of custody, if you will, is of the vaccine. The vaccine is being produced by, right now, Moderna and Pfizer. It's going to the federal government. The federal government isn't dispersing it based on population. They're trying to weight that, which means Delaware doesn't get a whole lot. We obviously get our share, so to speak. We have less than 1 million people in a country of 330 million, so we're not going to get a lot. But what we are getting, we're getting out the door. And right now, the more we get, the more partners we'll be able to group with, and the more primary care doctors who are interested in doing this will be able to get involved, and they'll be able to get more doses themselves. And all of that is dependent upon, obviously, more manufacturing, more doses being delivered to the state. But we obviously want to go there, and that's always been the plan. We are hearing from people who want to do that, but I'm also hearing from constituents who have gotten it from their primary care doctor. So that some amount of that is happening, but we obviously, as supply increases, want to do more and more of that.
Sure. I think the issues we are dealing with, just so that you can actually hear it directly from us. For example, the communication of the vaccine when it's going to be shipped, it's so random. Mm-hmm. So we were not expecting, for example, yesterday we have, the day before, we received, Dr. Barnett-Smith, feel free if I'm off with these numbers, but about 190 vaccine total doses that we received, and then we didn't know that it was coming actually. Now, I'm not really, I'm more solution oriented, so I'm not gonna give you a hard time for what is happening, but I'm just making sure that you know that what's available as resources for our state. We received that on Wednesday. Next day, 190 is completed in our Bexus location. And at my surgery center, we did about 95 vaccine. It took about 6 total hours. Now, just so that you have some perspective between the facility as like a surgery center, which is kind of like a hospital-like facility, versus primary care office. Primary care office yesterday, they did twice more. They probably did it so efficiently than the surgery center. Now, when I say this, our surgery center went out of their way to make this right for the patients. The problem is the setup. So, because in our Bex Foods location, we have about 24 exam rooms. So when you have 24 exam rooms and you have so many MAs who are used to do that, for them it's another vaccine versus at the facility, this is true for the hospitals, that's not something that they do on a regular basis. So they are going to be less efficient in terms of the run through of that day. Dr. Barnett-Smith, I don't know if I'm off with this one. We didn't talk about this, but what do you think?
No, I agree. We've been compiling a list of patients and basically been saying, be ready to go, because we have no idea if and when any vaccine is coming. But if you want to be on our list, as soon as we get them, we will call you. We literally had patients in tears when we called them to tell them that they could come in for their vaccine. One patient said he was going to camp out the night before because he was afraid that if he overslept, he'd miss his turn. And it just highlights how scared people have been that they're not going to be able to get access to this potentially life-saving vaccine. And I'm extremely proud of our Bexwood staff in the way that they basically from Wednesday was on the ball to be able to run a mass vaccination clinic in less than 12 hours. So I thought it was an amazing job.
Yeah, and that's we would love to see that ourselves. And I will say that you're not obviously the only ones experiencing that. Okay, so even folks who are receiving direct shipments from the federal government, so like large health systems like Christiana, were often completely unaware as to when these were going to show up. That they would just get a knock at the door, here you go, here's some doses. The state is getting a little bit more heads up than that, but it is still, it's unreliable when it's going to show up and how much you're going to get when you do get it. You do expect weekly doses to be delivered, but we don't always know how much there's going to be in that, which makes it difficult for us to communicate to the partners at the community level how many they're going to get, whether it's going to be, you said 190 or whether it's going to be 95 or what that's going to look like. So all of this goes back to what I think is I hope to see, if there's reason for me to remain optimistic in what we've seen so far, it goes back to what we experienced with testing, where it was sporadic. Supply was not something we could predict. We couldn't get it out there fast enough for people. But over time, there became a reliability in how many tests we could expect to get, how many we could administer on a weekly basis, and some projectability outside of 1 week or 2 weeks. And as we move through the vaccination ramp up with another vaccine coming online that is going to be much easier to administer because it only takes one, you don't have to worry about rescheduling, getting people back in for a second. The hope needs to be there that as this gets ironed out, you have a process that starts to emerge where not only does the state have some assurances 2, 3, 4 weeks out as to how many we can expect, so that can then be communicated down to our partners how much they can expect for the next 2, 3, 4 weeks. Because right now we're still running on that. Some's coming in the next couple of days, but we don't really know how much it's going to be. And we can't get assurances for how many we can expect 2 weeks from now. And when we get that, it'll obviously be a little bit easier to plan and not so much the doses showing up tomorrow. So we need to figure out how we're going to distribute to our partners in the next 3 days.
So, that's important for us to know, and which actually kind of brings me to my next point on our discussion. So the representation in terms of us, private practices and what we do. And I know in many cases, they're not so well organized, but there are exceptions like United Medical ACO providers. I represent about 60 different practices with close to 180 providers. This is the Delaware numbers. And then there's another private ACO, Alidate, as you know, and then there are 2 hospital ACOs. One of them has a partnership with Medical Society. So, and I'm going to tie this discussion to this, but the way that we see, there are a lot of committees in the state of Delaware. Most of them we go as a guest. We do have a couple of members now who are on different committees at different levels. There are 2 people. The issue that I see, which actually, again, there are discussions perhaps are happening, and then how much of that is available to us is kind of limited. And And I do believe that there has to be a better proportionate representation of private practices. In fact, two private ACOs, and the other ACO doesn't even know that I'm talking about on their behalf. They may not want to do it, that's their problem. But if the hospitals are getting default appointments for these committees, which they do, insurance companies, as you know, they get default appointments, like, for example, Mary Health Caritas, when they are new in town for 3 years, but as soon as they are here, they are given a committee membership. They're part of the board health options. Now, Highmark gets it in two different ways. They have it from health options, and they have it from Blue Cross side of it. Aetna has representations. Hospitals have representations. When you look at what can be achieved with the proper people being at the table is more, and then the issues that you are actually describing are resource and expertise level issues. We are going to push this as much as possible, but I believe accountable care organizations in Delaware should be getting the same level of representations as the hospitals are getting. Do you think you can help us with that?
Absolutely. I mean, you showed on the screen, you showed the makeup of the Primary Care Reform Collaborative. And just for the sake of people watching, that's not a group that works on COVID-related vaccine distribution. Okay, so the Primary Care Reform Collaborative is working on trying to create a sustainable long-term place for primary care practices, private practices, so that we don't continue to lose primary care practices and they don't continue to sort of either get gobbled up by health systems or shift to concierge or whatever. So just for the clarity of the folks watching, that this is not a group that's focusing on engaging primary care for the purposes of COVID vaccine distribution. So this is about payment issues and making sure enough of our primary care spend is going, or enough of our healthcare spend is going into primary care to make it long-term sustainable. I just wanted to make sure that was pointed out.
Mm-hmm. So I'm just, this is me typing or writing here. So sorry for the bad writing here, but I think this list, even this list, or any other state committee list, as you can see here, the Christiana Hospital Medical Society and the BB Hospital insurances, all great, but it's like the main players. Dave, I'm pretty sure you didn't think we were providing at a primary care level 116,000 patients in Delaware, right? So because every time we give examples in Delaware, we always use one or two other big hospital systems. But when it comes to primary care, we are it. So when it comes to private practices, like one of our groups is the biggest and only statewide cardiology group, Delaware Cardiovascular. And I think this is important for you to know. I probably did more J1 applications. That's for those places where you cannot hire physicians, so you use a J1 visa since year 2000. As an individual, I think I probably did the most number of J1 applications in the state of Delaware, because we are trying to help not just one part of the population, but the entire state. Our bariatric group is the like the 6 providers, and they're the most experienced group around the state. Our pulmonary group in Kent County is the only group as a pulmonary and sleep. So, and then all this doesn't actually get enough recognition. Now, we are okay, we have enough recognition in terms of different ways of seeing that, but I think being part of making the decisions and being part of that decision-making process, I think it's definitely needed and necessary for us to be at that table. And we are gonna ask if you can support us on that topic. When I talked to Valerie about this issue, she said, well, David would be your person to go to. And then, then here we are. So we have you. I'm not trying to really put you on spot, and I know that you are willing to help, and that's great to hear. I do want to also share one other thing, and I think one of your town hall discussions, you did cover this with the telemedicine. I can tell you it's every kind of crisis, it teaches us something, and there are always some silver lining. And I believe from COVID pandemic, the silver lining is the telemedicine and digital communication. And we have made a lot of changes. United Medical was one of the early adopters of telemedicine. In fact, Dr. Barnett-Smith was maybe one of the first in the PCP side who went almost 100% telemedicine on the almost overnight, right, Dr. Barnett-Smith? So we just want to make sure that we can actually continue on telemedicine. Just to kind of explain this, we were here for telemedicine, so that represents 0 in February 2020. With our business structure in the central office, with my office here, about Tanner is part of that team. With different directors that we have, we immediately pick this up and make this available so that our patients didn't have to leave their homes, and they wouldn't actually, they would still get the care that they need. But some providers, as you know, they are still feeling like they are not making this available for their patients. But what we also learned is even for the winter time with the flu season, for patients who are over 65, even if we didn't have COVID-19, this would be the way to treat those patients if they don't have to leave their homes. So we have your support on that as well.
Yeah, I mean, whether it's this issue or the one we just talked about engaging people on making primary care practices stronger, our interests are aligned here. So obviously, when the pandemic started, the governor took pretty swift action on telemedicine to make it as available as possible by basically through emergency order, basically canceling all the regulations around it that were really limiting it in a lot of ways. And we worked with him at the end of session last year to take a lot of that and put it in the statute and try to make it longer term. All of that is in place through the end of this legislative session. So we only did that for a year. So by this summer, those are going to start to expire again. But it is a goal, because I keep hearing this from providers across the board, from patients, that not only is this useful during a pandemic, but there are definitely long-term benefits in a post-COVID world for these new avenues of telemedicine. And we are working on legislation to try to take the current practices as they are right now and figure out a way to make them permanent. I mean, we can't keep operating the way we have been over the last year or so because it's kind of ad hoc. We're kind of just figuring out, we need to sort of put in the statute a long-term new policy around telemedicine. And I think what we've learned over the last year is that a lot of what we're doing, a lot of what, and the providers deserve a ton of credit for figuring out a way to take this up as rapidly as possible, and adapting and figuring out new ways to deliver care, that they keep telling us this is working. We want to keep doing it. We want to keep doing it in 2021 and 2022, and for the next decade, well past the time when hopefully COVID is dead and gone. So we want to work with everybody and make sure we have a system that works for people, from the patients, the providers, so that this technology can be utilized and be widespread, and everybody can have access to it.
It's also really important, like for you to hear it from us. And then I'm also, in some ways, I'm concerned when it's not, when we don't follow certain standards from the provider standpoint. I'm speaking from our central business office. As soon as this was needed, we start supporting our providers with hardware, technology, and different software. And it needs to be at some point integrated with our EMR systems. So they cannot really just do it the way that with those, kind of temporary conditions that we had in the beginning of COVID. Mm-hmm. And now our EMR, we are using it through our EMR, which is integrated in our system, which does increase patient participation with patient portal and others. I do want to make sure that the standards are not being compromised in any way, but I think it's a great resource for our patients and also for our providers. Like last week, we had 2 snow days. One of them at least was bad. And, we have, as I mentioned, 60 different practices, and that's a lot of different locations. So our offices, we didn't cancel any of our appointments because most of them are already on telemedicine. But some offices who didn't use telemedicine, they had to close down their offices.
Mm-hmm.
So while providers can do this through telemedicine, in many cases we need to be able to talk to our patients, and if we are able to see them, and that's you don't need to be in person, not 100%, but 92% of the time. I'm just making that up, but 92% of the time you don't have to be in person. So I think the certain standards have to be maintained, and I know that we are really trying hard on that. Now, I have one other topic that I did introduce this last week, and this is also another struggle that we are having. And I know state of Delaware has certain things in place, but I just want you to kind of see certain discrepancies between the insurance takebacks from provider offices versus their payments. And the, how we talk about different inequity. So like this is on the racial side, this is on that side, this is on this side, but I think it's all about the power. Like whoever has the power is just ruling. And this, what I'm sharing here with you is different insurance companies and their timely filing limit. So I'm going to use Aetna as an example. Aetna wants me to file something in 4 months, which is reasonable. And I understand why that would be. But then once something is denied, even if it's their mistake, that denial needs to be corrected from us in 6 months. Well, honestly, that's also reasonable because we should be all working on it. That's fine. That's 10 months. However, Aetna can come back and take money back from our future claims, even for date of services up to 24 months with no really proper warning. And I'm not just speaking for Aetna. In this case, it happened with different insurances here. I'm not going to name all of them. And I'm using Aetna as an example because they are on the bottom of this first window here. So now, as you can see, they have 24 months to retrieve a payment from us. And that money is being taken from the future payments of other patients. But then I have to do everything in 10 months. Now, this from the business side is a huge problem for us. I'm not going to go to the specifics, but what they have done with our surgery center at the end of December, especially with the COVID issues that we have, we weren't maybe paying close attention to some. And then all of a sudden we realized that we were missing close to $200,000 money from Aetna. And because they were just showing payments on future claims, and then they took the money back with no proper documentation in place. Now, some of those claims are going up to 24 months. And now we have to kind of struggle with this whole situation to figure out, because the money is already taken back. So undoing it and doing it right is going to be almost impossible. But I was hoping that state can actually have certain limitations, like this 24 months. If they can be done in 10 months, why cannot be done in 12 months, for example? Can we actually discuss this more later on? We can give you some more specific examples, because I don't want to mislead you in any way. Yeah. I never have done that. So I will give you my data, my statistics from my business office. But we do need help with these types of discrepancies, and we are going to need your support, hopefully.
So this is a problem that's honestly, it's never been articulated to me before by somebody. So please excuse my sort of unfamiliarity with it or inability to sort of give you more concrete thoughts on it. But certainly, the state has mechanisms to make sure to enforce regulations on insurance companies and things like that. If something is determined inequitable and unfair in some way. I don't know whether there's already regulations that's setting this at 24 months, and what's sort of governing this system now is something I'm also unfamiliar with.
24 months is on the state regulation. Now the problem is a little bit more, because as we talked to the insurance commissioner, and he's a good guy. He does help us when we need support. The problem is they have restrictions on self-funded plans. If it's the TPA businesses I'm talking about, like Blue Cross and Aetna, they have 75% of their business is not the insurance business, it's the TPA business.
Mm-hmm.
So they're self-funded plans, the employer, they're administrating those. It becomes a really big problem. And you're right, probably this was not escalated to you guys. And if we have some follow-up meetings, I would like to just give you some background on this with the data, and then we can actually talk about it and then see if there's anything you can do for us.
Absolutely.
So before we close, I do want to make sure, so we are, now it's almost like a TV channel, guys. So we have our YouTube channel is pretty well updated. We have same, standard events. Every Friday we do this. And also on Wednesdays, we have our diabetes program updates, second and fourth. Every Wednesday, 3 p.m., we have bariatric updates with Krias, and our behavioral health update every once in a while. So we have made this available for our patients. And again, the silver lining is there. So yeah, every crisis, we have different things that we can learn, and hopefully we cannot repeat those mistakes in the future. And I think that's one of the greatest thing is the digital health and how to make this available and accessible for public. That was one of our biggest gain from our point. And just having this event with so few here. So well, Tanner, you can join us if you are still there. I know you are there, but well, thank you so much again. And I'm going to ask both of you if you have any closing comments that we didn't maybe capture anything.
No, I just appreciate the opportunity to be here and hear about, the issues you're facing, and, how we can sort of work collectively to try to make things better.
Thank you. Dr. Barnett-Smith, are you, is your connection still broken? No, we cannot hear you.
Okay, no.
No, we can hear you.
Okay. All right. Just thank you for allowing me to be here again. I really take to heart the issues of racial disparities and some of the inequities that we're trying to overcome in our communities. And I appreciate the opportunity to have the platform and to be able to connect with people that are willing to help, like Representative Bentz. So thank you, and I look forward to being on.
Thank you, Tanner. Thank you again for helping us with everything that you did. Thank you, guys, and then we'll be back next week at same time, Friday at noon.